Good morning, dear students. I am Dr. Minthami Sharon, Associate Professor from the Department of Obstetrics and Gynecology. I am here to speak about anemia complicating pregnancy. So in India, anemia complicating pregnancy is a very important problem, and the most common form of anemia which we encounter in India is iron deficiency anemia. Today's lecture is based on iron deficiency anemia in detail. So, iron deficiency anemia is a very important exam question. It can come as a short notes, it can come as an essay, and it's a very important practical exam question. So, the most common case, capital B iron deficiency anemia case for you. So, today's learning objectives would be, at the end of the lecture, you should be able to define anemia, you should be able to classify anemia, you should be able to describe the etiology of anemia, and also understand the pathophysiology. You should be able to diagnose anemia when you encounter a patient and prescribe them investigations to confirm your diagnosis. And you should be able to understand the effects of anemia on the mother and the fetus, and the problems which occurs during the antenatal period, during the intrapartum period and the postpartum period. And you should learn about the management of anemia during the antenatal, intrapartum and the postpartum period. And last but not the least, you should know about the complications we encounter due to iron deficiency anemia. So first we learn about the definition of anemia. Anemia is defined as reduction in the red cell mass or the hemoglobin mass in the body, which leads to impaired oxygen carrying capacity in the blood. When the hemoglobin concentration is less than 10.5 grams per deciliter, we call it as anemia. The World Health Organization defines anemia based on the period of gestation. So, the first and the third trimester, if the hemoglobin is less than 11 grams per deciliter, or the hematocrit is less than 33%, it's called as anemia. And in the second trimester, it's further less because of the hemodilution. If the hemoglobin is less than 10.5 grams per deciliter, or the hematocrit is less than 32%, we call it as anemia. And in immediate postpartum period, for the first 1 week, if the hemoglobin is less than 11 grams, it is defined as anemia. So, after the postpartum period, that is at the 8th week postpartum, if the hemoglobin is less than 12 grams per deciliter, it is defined as anemia. So this is how the World Health Organization defines anemia. So there is no uniform cutoff value. It varies according to the period of gestation and the postpartum period. So what is the prevalence and incidence of anemia? According to the World Health Organization, 40% of pregnant women are affected with anemia. The National Family Health Survey of 2015 to 2016 conducted in India gives a prevalence of 50%, whereas there are many studies which shows a higher prevalence of about 80 to 90%. First, before going to anemia in detail, we need to know the normal hematological changes which occur during pregnancy. So there is an increase in the blood volume by 30%, and there is an increase in the plasma volume by about 50% from the 6 to 8 weeks onwards. And the peak increase in the plasma volume occurs at around 32 weeks. There is also an increase in the RBC volume by around 15 to 20%, which begins at 20 weeks and continues till term. The increase in RBC volume in proportion to the plasma volume is lesser. So there is a hemodilution state during pregnancy which causes a physiological anemia in pregnancy. The WBC count also slightly increases in the second half of pregnancy. It's around 12,000 to 14,000 cells per hypophale. During labor, it increases to 20,000 to 30,000 cells. The platelets, usually there is no change during pregnancy. In the postpartum period, there is a thrombogenic state and there is an increase in the platelet count. The ESR increases to 50 to 60 millimeter in the third trimester. There is no change in the bone marrow, but there is a slight increase in the plasma cells and the megakaryocytes. The serum proteins, the albumin is reduced by 1 gram. And there is also increase in the fibrinogen by 400 to 600 milligram. So next we go into the classification. The World Health Organization again classifies anemia according to its severity. So mild anemia is hemoglobin values between 10 to 10.9 grams per deciliter. Moderate anemia is between 7.9 to 9 grams per deciliter. And severe anemia is less than 7 grams per deciliter. We can also classify anemia based on the etiology. It can be classified as nutritional deficiency anemia, hemolytic anemia because of the increased red cell destruction, and anemia associated with decreased production of blood cells, anemia associated with other hemolytic diseases, and anemia due to chronic blood loss and other comorbidities like hypothyroidism. So, anemia associated with nutritional deficiency. What are the most common nutritional deficiencies which occur? They are the iron deficiency anemia, which is very common. Next is the folic acid deficiency. Next, vitamin B12 deficiency. And there can be a combined deficiency of any of these three vitamins. Then anemia associated with increased red cell destruction. When there are any inherited hemoglobinopathies like the sickle cell anemia, thalassemia major, minor, and hereditary spherocytosis, that's increased destruction of the red blood cells and which leads to anemia. And anemia is associated with decreased production of red blood cells because of the diseases in the bone marrow, and then can be bone marrow suppression because of any chemoradiation. And if there is a chronic renal disorder, there may be a decrease in the erythropoietin level which causes a decreased production of the red blood cells. Hypothyroidism also causes chronic anemia. Acquired hemolytic anemias can be due to autoimmune diseases, and it can also be associated with thrombotic thrombocytopenic purpura or hemolytic uremia. And it can most commonly occur due to malaria. Then anemia due to blood loss. The blood loss, any chronic blood loss may lead to anemia, like because of heavy menstrual bleeding or because of any gastrointestinal bleeding due to any worm infestation or due to obstetric hemorrhage following a postpartum hemorrhage or following repeated abortions. Also there can be anemia. Iron deficiency anemia. So it is the most common cause of anemia in India. So what does a normal diet contain? It contains about 10 to 20 milligram of iron. Iron is usually absorbed in the duodenum. About 10 to 20% of iron is absorbed. So when there is 10 to 20 milligram of iron in the diet, only 1 to 2 milligram of iron is absorbed daily. And the daily loss of iron is around 1 to 1.5 milligram. This occurs through urine, sweat and the menstrual blood. Why is iron deficiency more common during pregnancy? Because In pregnancy, there is an excess demand. The demand is distributed this way. Like the fetus and the placenta requires around 300 milligram of excess iron. Maternal hemoglobin expansion requires an excess of 500 mg of iron. The blood loss during delivery, to compensate it, there is an excess requirement of 200 milligram. And to replace the usual loss of iron through the urine, sweat and the feces, there is an additional requirement of 200 milligram of iron. So, we have to supplement this excessive loss or excessive requirement of iron during pregnancy through the diet. So, during pregnancy, the daily dietary requirement of iron is increased to around 60 milligrams per day. So, since the absorption is only 10%, around 6 milligram of iron will be absorbed in the body. So what are the causes of iron deficiency anemia in developing countries like India? Firstly, it is due to the insufficient dietary intake. This insufficient dietary intake may be because of limited resources or low iron containing diet. So most of the Indians are vegetarians and vegetables are very poor in iron content. So there will be a low iron intake. And there can be defective absorption of iron because of high levels of phytates in the diet. When we take too much of green leafy vegetables like greens and all, they will contain a lot of phytates which can hinder the absorption of iron. And there can be a coexistent deficiency of vitamin C and vitamin A which will reduce the absorption of iron. So there can be an increased iron loss. This usually occurs due to too many and pregnancies, that is too frequent pregnancies. So they do not give adequate birth spacing. And if they do repeated abortions also, it can lead to increased iron loss. And during the postpartum period, there can be postpartum hemorrhage and excess of bleeding which can lead to iron deficiency anemia. Most commonly in India, there is going to be a hookworm infestation which will be the most common cause of anemia, and there can be chronic malaria which causes anemia. Also, if there is blood loss chronically because of hemorrhoids, there can be anemia. Also, if there are low iron stores because of the short interpregnancy interval and multiple pregnancies, occurring in 2 short intervals, there won't be enough time for the body to replenish the iron stores which iron it has lost. So, during every pregnancy, there will be loss of iron because of the increased demand and blood loss associated with their childbirth. So, body requires time to replenish its iron stores. If the adequate time is not given, then the iron stores by say it will become low. So, what are the symptoms of severe and chronic anemia? Mild to moderate anemia, patients can present as fatigue, increased malaise fatigue. Then they can have headache, intolerance to exercise. They will not be able to walk even for a short distance. They may not be able to climb stairs. They'll have excess of dyspnea and they'll feel very tired. They may have giddiness. They may have palpitation and edema in the limbs or the whole body also if the anemia is very severe. So the worst problem of anemia is congestive cardiac failure. In case of very severe anemia, that is less than 6 grams per deciliter, congestive cardiac failure is very common. And symptoms of congestive cardiac failure are again dizziness, palpitation, all those things can occur. So what are the signs? So signs are things which we elicit. So we'll have to look for pallor. Where do we look for pallor? We can look it on all the mucosal surfaces, starting from the palpebral conjunctiva, the nail beds, and in OG, specifically you can look in the vaginal mucosa also when you do a examination. And then specifically for iron deficiency anemia, there is spoon-shaped nails called as koilonychia, and there can be a glossy tongue. The papillae in the tongue will become atrophic, and it will become lost. It will get lost. So there will be a smooth tongue. So that's called as a glossy tongue. And there can be angular stomatitis because of iron deficiency anemia and other associated vitamin deficiencies like B12 deficiency. So if the iron deficiency anemia is because of chronic malaria or any other hemolytic problems, there can be splenomegaly. And because of the severe iron deficiency anemia and the excess of hyperdynamic flow in the system, there you can hear a systolic murmur in the aortic area. It's called as a hemic murmur. And in case of severe anemia, there is signs of congestive cardiac failure like pedal edema or generalized edema, which is called as anasarca. There can be tachycardia and hepatomegaly, and there can be crepitations in the lung bases in severe failure. So how will you diagnose anemia? Anemia is diagnosed by doing simple blood tests. First is by the signs. Once you get the clinical signs pointing towards anemia, you have to confirm your diagnosis by the following tests. The simple first test is hemoglobin concentration and the hematocrit value. This is the main test because we classify anemia we classify the severity based on the hemoglobin value, and then you have to do a complete blood count to look for the low RBC count, to look for the WBCs and the platelet count, so that you will be able to have an idea about the type of anemia. Then red cell indices can be calculated. Usually in iron deficiency anemia, the mean corpuscular volume is less than 80 femtoliters, and the mean corpuscular hemoglobin concentration is also very low, and it is less than 30%. So this is very, very specific to iron deficiency anemia. And if you're given only one opportunity to do only one test to find out and classify anemia, then you will have to do a peripheral blood smear. It's a very gold standard test with which you can find the type of anemia, the degree of anemia also to some extent, and the cause of anemia also. So usually in iron deficiency anemia, we have microcytic and hypochromic RBCs. Also there is anisocytosis and poikilocytosis. You can also do other iron studies to look for the iron stores. So when you do iron studies, you have to look for the iron stores by seeing the ferritin levels. Usually the ferritin levels will be low. Next, you can look for the serum iron levels, which will also be low. But there will be an increase in the total iron binding capacity of the RBCs. So what are the other tests to determine whether it is of non-nutritional etiology? So if it is because of the chronic blood loss, because of worm infestation, it can be found out by doing a simple stool examination. Then in the peripheral smear, you can also see malarial parasites, and you can also do a urine routine examination to look for the microscopy to rule out any chronic renal diseases which can lead to iron deficiency anemia. Obstetric consequences of iron deficiency anemia. So what is the problem? Why are we worried about iron deficiency anemia occurring towards pregnancy? Because it affects both the mother and the baby, and it causes damage to the mother and the baby during the antepartum, intrapartum and in the postpartum periods. So what is its effect on the mother? So most commonly, because of iron deficiency anemia, there's going to be chronic hypoxygenation, and there will be chronic decreased oxygenation to the fetus. So the baby will become low birth weight babies, and they will lead code for intrauterine growth restriction. Okay, and the mother will have preterm birth. So most commonly anemia will be correlated, like coexistent with hypertensive disorders during pregnancy. And there can be poor tolerance to blood loss. So if the patient is, the mother is having even little blood loss, she won't be able to tolerate it during the delivery. Then the iron deficiency anemia can lead to cesarean sections because of the problems which occur during labor. Then there can be puerperal sepsis. There will be subinvolution of the uterus. Because of the iron deficiency anemia, the mother will be immunocompromised, so she is more susceptible to have sepsis. And the other problems following postpartum. So in the postpartum period, there will be even increased chance of thromboembolism because of the hemodilution, and there's going to be postpartum depression. There will be lactational failure because of even a simple blood loss. If the mother is already anemic, she won't be able to tolerate, so it will lead to lactational failure also. So what are the problems which occur in the fetus? So as I told you earlier, the fetus can be a intrauterine growth restricted fetus, so it will have a low birth weight, and because of the preterm birth, the fetus will have all problems of prematurities. Like so they are more prone for ARDS and other perinatal morbidity and mortalities. So they also have a low iron stores at birth. So the baby will become chronically anemic even after birth. So we have to supplement the baby iron deficient mother with iron in the postpartum, like in the immediate neonatal and the post neonatal period. Also, the long-term effects because of the chronic hypoxygenation, it can lead to poor mentation and psychomotor performance of the baby. In severe cases, when the hemoglobin is less than 6 grams per deciliter, it leads to severe hypoxygenation in the fetus, which leads to the problem in the fetal heart rate patterns. The fetal heart rate patterns will become non-reassuring, and there will be fetal cerebral vasodilatation. It's called as a brain sparing effect. So in very severe cases, anemia can also lead to fetal death. So prevention. Prevention is always better than cure, so you can prevent anemia. There is a National Anemia Prophylaxis Program which is happening in India, when every pregnant woman is given 60 milligram of elemental iron and 500 microgram of folic acid for at least 10 days during pregnancy. The WHO recommends to give 120 milligram of elemental iron and 500 milligram of folic acid. So treatment of iron, it mainly depends on the severity of anemia and the period of the gestation. The first line treatment for iron deficiency anemia is oral iron therapy. So what is the dose? It's double the prophylactic dose, which is 120 to 200 milligram per day. And preparations which can be given orally are the ferrous fumarate, the ferrous sulfate, and the ferrous gluconate. So this is a flow chart showing the management of iron deficiency anemia in pregnancy. If the hemoglobin is less than 5 grams per deciliter in all trimesters, it doesn't matter which part of pregnancy she is in, you have to evaluate for the cardiac decompensation and transfuse packed cells with close cardiac monitoring. So this is the worst extreme. And if it is very mild anemia, also it is between 9.1 to 10.9 grams per liter, with respect of the trimester or the period of gestation, you can give oral iron therapy and along with folic acid in the therapeutic dose which I told you. So it will be given as twice 2 tablets per day. So the problem occurs when it is somewhere in between. So if the hemoglobin is between 5.1 to 7 grams per deciliter, then treatment of iron deficiency will be according to the period of gestation. If you detect it at a very early gestational age, that is in the first trimester, we can try giving oral iron therapy with folic acid, as I told you before, in the therapeutic dosage. If it is the second or the third trimester, you can prefer IV iron therapy. So you have to look for the hemoglobin rise after 1 month. If the target hemoglobin is achieved, if there is the hemoglobin rise is adequate, then you can continue and the patient on oral iron therapy. If the target is not achieved, if the hemoglobin rise is not adequate as expected, then maybe the patient is non-compliant, she's not taking the iron tablets properly, or the absorption is not good. So if you detect it early in the first trimester itself, you can give IV iron therapy if it is not contraindicated. Also, you can consider about blood transfusion. If you detect it around in the second or the third trimester, you have to give iron by IV infusion. If this amount of hemoglobin, that is 5 grams to 7 grams, if you find it during the end, that is after 36 weeks of gestation, then there is no other option, we have to transfuse packed cells. So if the hemoglobin is somewhere between 7.1 to 9 grams, what shall we do? For all trimesters, again, we can try oral iron therapy at the therapeutic dose and repeat the hemoglobin after 1 month. Same way, if the hemoglobin target is not achieved, then you consider the IV iron therapy, and if the hemoglobin target is achieved, you can go for oral iron therapy. If the same thing is detected at end of pregnancy around 36 weeks, so you can directly go for IV iron therapy. So this is how you will decide what type of iron to be given, whether you have to give oral, you can continue oral, or you have to give IV, or you can continue IV, or you have to go for blood transfusion. So this is a very important flow chart which will help you to decide on the mode of treatment. So parental iron therapy, oral iron we have already spoken about. So parental iron therapy, the most important indication is moderate to severe anemia. So the common preparations are the iron dextran complex, which is given as IM iron, the iron sorbitol citric acid complex, which is also given as IM iron, and sodium ferric gluconate complex, which is given as intramuscular. So previously they were all in favor of intramuscular injections of iron. The intramuscular injection had severe side effects, like it used to be very painful, it will form injection abscess, it will form pigmentation of the skin. So they used to follow a technique called as the Z-tag technique, where they insert the needle in the form of a Z so that the pigmentation doesn't occur on the skin. But nowadays we have in handy the iron sucrose infusion, which is very good. We give IV iron transfusion. It is safe. Most of the time it doesn't produce any adverse drug reactions, but we have to be very vigilant before giving the first dose. So what we do is, usually the vial will have 2 ml of iron sucrose, and each ml will contain about 50 milligram of iron. So you have to give 200 milligram of iron in 100 ml of NS per day. It can be given over a period of 15 to 20 minutes, and you can repeat the dose every alternate day. So there is another component, but this requires lot of dosages. So at one sitting we can give only 200 milligram of iron. So you will require around 8-10 things of iron sucrose infusion. So the other thing which has come recently in the market is the iron ferric carboxymaltose complex. Initially, it was advised only for the postpartum period, but nowadays we are giving even in the antenatal period. It contains 20 milligram, like 1000 milligram of iron will be there in the dose. So what happens is you have to calculate the dose 20 milligram per kg body weight and give it over 15 to 20 minutes. The problem with this iron ferric carboxymaltose is it is very prone for adverse drug reactions. So you should be very careful. I should keep all emergency medicines ready before giving this infusion. So before giving all this iron preparation, IV dosages, we have to calculate the iron requirement by the female. Okay. So how do we calculate? There are two formulas. One is based on the body weight in kgs. The other is based on a body weight in grams. So sorry, not grams, pounds. Okay. So first calculation is 2.4 into pre-pregnant weight. You should not calculate the present weight. Okay. The pre-pregnant weight of the mother in kgs and multiplied by the hemoglobin deficiency. So 2.4 into pre-pregnancy weight in kg into hemoglobin deficiency. Okay, the deficiency means it will be 14 minus whatever the hemoglobin they are having now, that value plus 1000. So multiply all these three values and add 1000 for the stores. So that will be the total iron which you will have to infuse. So if you are going to choose iron sucrose infusion, it will have only 200 mg in one vial. So you will require multiple dosages. Whereas in iron ferric carboxymaltose, it will have 1000 mg. So it may require only maximum 1 to 2 doses. The other way which we can calculate the total iron dose requirement is the other formula, which is 0.3 into pre-pregnant weight in pounds into hemoglobin deficiency plus 1000. So in India, we usually measure weight in kg. So the first formula is more appropriate and useful. So next, the management of labor. So labor is a very important event during pregnancy and it is the climax of the pregnancy. So you should be very careful. The patient has more chances of growing for congestive cardiac failure during labor and all the problems which occurs because of the chronic hypoxygenation may precipitate during labor. So you should be very, very careful. So regarding MTPs in the first trimester, very big no. In the case of severe anemia, please don't do MTPs because chance of infection is more, chance of sepsis is more, and then you will be in trouble. So try to avoid MTPs and let the patient go into spontaneous labor. Do not induce labor. We will wait for the patient to go for spontaneous labor. So in the first stage of labor, the patient should be at rest. You should not ask the patient to walk around because she is already compensated. The cardiac status is decompensated. So you have to give her rest. Okay. And you can give her oxygen if the SpO2 is less. And you can start her on prophylactic antibiotics. IV antibiotics itself you can start. Because sepsis is very common during the postpartum period. In the second stage again, you should not do ARM. Okay, our ARM is artificial rupture of membranes. So repeated PV should not be done. Artificial rupture of membrane should not be done. And you should not allow the mother to bear down for a very long time. Okay, because it requires the valsalva maneuver and the bearing down effects. It will compromise the heart again, which will cause the problems. So, and you have to cut short the second stage, usually with an outlet forceps. So, previously we were giving prophylactic methogen. Nowadays we don't practice giving methogen. We are giving oxytocin instead. The prophylactic oxytocin, that is the active management of third stage of labor, can be done. So in the active management of third stage of labor, we give 10 units of oxytocin IM immediately after delivery of the baby to reduce the postpartum blood loss and to facilitate immediate uterine contraction. So in the immediate puerperium, again, the patient is more prone for subinvolution of the uterus and puerperal sepsis. So it should be given adequate antibiotic cover. So in the role of digoxin during labor is controversial. It may be helpful if the patient is in failure. That is failure in the sense the cardiac failure. So digoxin may be helpful but not otherwise. And then during what is the role of lactation? Usually in case of severe anemia because of the chronic blood loss, there will be lactational failure. Okay, so you have to initiate lactation immediately after delivery and you have to encourage the mother to feed the baby. You have to give galactogogues and support feeding. Then immediate postpartum period, you should give her adequate contraception so that she doesn't immediately conceive and worsen the pre-existing anemia. So the contraception of choice which we give immediate postpartum is the barrier contraception. So dear students, today we have learnt about the definition, the classification, the etiology, the pathogenesis of anemia. Also, we have gone through iron deficiency and anemia in detail, its management. You have learnt about the various iron preparations, its mode of administration, complications, and the management of anemia during pregnancy and the intrapartum period, and also its complications. So this is a very important exam question. So please go through it in detail and learn it from your textbooks in further detail. Thank you.